Hello, everyone. I want you to take a moment and to look at this picture of women. I want you to think about what is similar and what is different about them. They all look like they're smiling, they look happy, they look satisfied, and they all have different weights. And I'm going to assume that you're thinking the same thing. However, what if I told you that 8 or 9 out of these 10 women were unhappy with the way they looked? Would you believe me? As a result of this unhealthy body image that women and girls have, it leads them to participate in unhealthy dieting, which eventually leads to eating disorders. My name's Baheshta. My group members Ahmed, Mohsin, Mohammed, Saqib, and Marina have put together this presentation talking to you about eating disorders, putting the main focus on anorexia. The agenda for this specific presentation is as follows. We're going to have the introduction and background, statistics and epidemiology, characteristics and symptoms, causes of eating disorders, treatments, a specific case study, media influence, as well as the conclusion. Eating disorders are complex conditions that arise from a combination of long-standing behavioral, emotional, psychological, interpersonal, and social factors. We can all benefit from watching what we eat and regular exercise throughout the week in order to maintain optimal health. However, watching what we eat is not an eating disorder. Eating disorders are mental illnesses. They're not simply a lifestyle choice that people make. Individuals with eating disorders often use food in an attempt to compensate for feelings and emotions that may otherwise seem overwhelming, such as a person thinking they're too fat or ugly, and the only way they can feel better about themselves is if they lose a couple of pounds here and there. For some, dieting, binging, and purging may begin as a way to cope with painful emotion. However, this could lead to serious life-threatening complications. So now the question is, why are eating disorders so significant? Well, studies have it, eating disorders have increased threefold in the last 50 years. Over 1/2 of teenagers and 1/3 of teenage boys use unhealthy weight control behaviors such as skipping meals, smoking, fasting, vomiting, or taking laxatives. Another study showed 90% of all cases are young women and adolescent girls, and almost 50% of people with an eating disorder meet the criteria for depression. So now we're going to be talking about the history of eating disorders. So eating disorders started out during the late 12th and 13th century in Western Europe. Women who starved themselves were referred to as miracle maidens. They were highly respected because of their behavior, and they saw it as a religious act. An example of this was seen in Catherine in Siena during 1347 to 1380. She took the same approach where she did not eat any food and was respected in the community and seen as a saint for her religious devotion. However, by the 16th century, the Catholic Church began to disapprove of any forms of dieting. The first person who actually died of dieting was reported in 1689 by Richard Morton. He referred to it as wasting disease of nervous etiology. And the first description of anorexia is, however, credited by Sir William Gall. He was a physician to the Queen Victoria, who in 1868 named the disorder anorexia hysterica, emphasizing what he believed to be a psychogenic origin. There are 5 types of eating disorders. There's anorexia nervosa, bulimia nervosa, binge eating disorder, purging disorder, night eating syndrome. However, the focus of this presentation will be specifically on anorexia nervosa. So now the question is, what is anorexia nervosa? Well, Harper in 2014 defined it as a refusal to maintain body weight at or above the minimally normal weight for age and height. So weight loss leading to maintenance of body weight less than 85% of that expected, or failure to make expected weight gain during period of growth, leading to body weight less than 85% of that expected. So basically, a loss of 25% of your original body weight is seen as anorexia nervosa. So why is this so significant now? Well, it's significant because these changes in one's body will damage a person's physical, emotional health, self-esteem, and a sense of competence and control. So now that we know why anorexia nervosa is so significant, let's back it up with some statistics and epidemiology. According to recent research, it has been seen that 15% of girls in grade 6 are on a diet. We also have 30% of girls in grade 6 who say they are self-confident, and that percentage drops to 14% of girls in grade 10 who say they are self-confident. We also have over 15% of all girls who say they wish they were someone else, and that's very unfortunate. In addition, 9 out of 10 girls say that they feel pressure from the media to be thin. According to eating disorders in Canada, nearly 1 million individuals are diagnosed with eating disorder at any given time, while we have 1 in 2 report knowing someone, including themselves, who have or has an eating disorder. 90% think that the media pressures to have the perfect body drive individuals to develop eating disorders, and 40% believe eating disorders are a choice. We also have 1 in 3 admit they wouldn't be able to recognize the warning signs, while 89% believe eating disorders are preventable. In addition, according to statistics, eating disorders among girls and women in Canada together, anorexia and bulimia, kill an estimated 1,000 to 1,500 Canadians per year. So now we're going to move on and talk about characteristics and symptoms of general eating disorders, as well as those characteristics that are specific to anorexia nervosa. So it is important to know the common eating disorders, warning signs, and symptoms. Many eating disorders share the same characteristics, which may indicate an eating disorder that is developing or is being experienced in full. So we have 3 different things that we're going to be talking about in this: behavioral warning signs and symptoms, the physical warning signs and symptoms, as well as psychological warning signs and symptoms. When we talk about behavior warning signs and symptoms, we talk about continuous or repetitive dieting. For example, an individual continuously counts his or her calories. They skip meals or they fast for long periods of time. We also have excessive or compulsive exercising patterns. So for example, someone exercising even when they are injured, or even if the weather is bad, or they refuse to interrupt exercise for any other reason. Instance, performing a certain number of repetition of exercising, or exhibiting distress if unable to exercise. In addition, eating only from a limited number of foods, such as only eating meat or dairy, and replacing meals with fluids. Strong attention to body shape and weight. This could include interest in body loss websites and magazines, following dieting tips presented in the media, or images of thin people. They're completely obsessed with this. Escaping from all social situations involving food, such as avoiding going out to dinner, avoiding previously enjoyed activities. It could be anything. We also have strong attention to body shape and weight checking. This would include pinching waist or wrist, repeated weighing of self, and excessive time spent looking in the mirror. In addition, they also spend a long time in the toilet after eating. So now we're going to be talking about the physical warning signs and symptoms. So we have unexpected or significant weight loss. We have frequent changes in weight, sensitivity to the cold, so they feel cold most of the time, even in warm environments. And that's usually because of the iron levels of that individual. So if they're not getting enough nutrients, they're very sensitive to cold. You also have loss or disturbance of menstrual periods. This is mostly focused on females. We also have signs of frequent vomiting, abdominal distress, fainting and dizziness, as well as fatigue. Now we can move on and talk about to talk about some of the psychological warning signs and symptoms. So, individuals who excessively eat increase their worry about their body shape, weight, or appearance. So, the person believes he or she is fat, even when he or she is actually normal body weight or even underweight. They also have the intense fear of gaining weight. They have a negative body image. They always worry. They have anxiety around meal times. They feel depressed most of the time. Their unusual moodiness, or they get irritable very easily. They're irritable about certain situations. They have low self-esteem, and as well, they're very confused. In terms of anorexia nervosa, which is the most common eating disorder, is mostly the same general characteristics of eating disorders, but this list shows its specific signs and symptoms. Anorexia nervosa is characterized usually by drastic, intentional weight loss, so an individual has a BMI that's less than 17.5. They usually overtrain or overexercise. They have thoughts of suicide or self-harm. They frequently avoid eating meals, so they always make excuses not to eat during breakfast or lunch or dinner, so they always make excuses for themselves. They are in denial of hunger. They're depressed and heightened anxiety around meal times. They also have irregular heart rhythms. They feel dehydration as well as constipation. In order to confirm a mental disorder like anorexia nervosa, physicians and health professionals have used several diagnostic criteria manuals to match against a person's symptoms. The most widely used diagnostic criteria for anorexia is the Diagnostic and Statistical Manual of Mental Disorders, or the DSM, which is a publication of the American Psychiatric Association. The matching process of a person's symptoms will help clinics and physicians decide whether the individual meets the diagnosis for anorexia nervosa or not. According to the DSM-5 criteria to the diagnosis of having anorexia nervosa, a person must display the following: persistent restrictions of energy intake leading to significantly low body weight in context of what is minimally expected of age, sex, development, trajectory, and physical health. Second one is either an intense fear of gaining weight or becoming fat, or persistent behavior that interferes with weight gain, even though they're significantly low weight. The third one is disturbance in a way one's body weight or shape is experienced, undue influence of body shape and weight on self-evaluation, or persistent lack of recognition on the seriousness of the current low body weight. The World Health Organization uses the Body Mass Index, or the BMI, as an indicator to know the level of severity of anorexia nervosa. The level of severity is considered by 4 different types. It's either mild, moderate, severe, or extreme. Mild, if a person's BMI is more than 17 kilograms per meter squared. It's moderate if the BMI is between 16 to 16.99 kilograms per meter squared. It's severe when the BMI is 15 to 15.99 kilograms per meter squared, and it's extreme when the BMI is less than 15 kilograms per meter squared. Causes of eating disorders. For the purpose of this presentation, we'll be focused on 4 different types: the biological, the social causes, the interpersonal causes, as well as the psychological causes. When we look at the biological, studies have found that those who do participate in not eating, they have an unbalanced chemicals in the brain. It often runs within their family, and there's a significant genetic contribution to eating disorders. The social causes of eating disorders are usually cultural. They glorify thinness. As well, cultural norms that value people on the basis of physical appearance. When we talk about the interpersonal causes, people have trouble making personal relationships. They have difficulties expressing emotions and feelings, and they usually have symptoms of being teased and ridiculed based on their size or weight. And the last thing that we're going to focus on is the psychological causes of eating disorders. So this looks at low self-esteem, feelings of inadequacy, or lack of control in life. Now that we have already spoken about the causes of eating disorders, we're going to focus on the outcomes of anorexia nervosa. So some of the outcomes are abnormally slow heart rate and low blood pressure, which means that the heart muscle is changing. The risk for heart failure rises as the heart rate and blood pressure levels sink lower and lower. There's also a reduction in bone density that leads to osteoporosis, which results in dry and brittle bones. Individuals also experience muscle loss and weakness, severe dehydration, fatigue and overall weakness. They also have dry hair and skin and experience hair loss, growth of downy layer of hair called lingo all over the body, including the face, in an effort to keep the body warm. Other ones are also cardiac arrest, electrolyte imbalances, suicide, in addition to death.
How do you think the media portrays eating disorders? Well, if you look at these pictures, they all have one thing in common, that being they all are thin. How does it affect others? Well, young females risk their lives and health trying to get the body shape presented by the media. Exposure to media images, messages, and advertisements play a negative role in young females' mood state and body image. According to United States researchers, 94% of females appear on the TV are thinner than the average American females. TV programs also show the importance of being thin and the ways of attaining the thin body shape through dieting, over-exercising, or even through cosmetic surgery. As a result, young females believe that they should become thin in order to be beautiful. Yuko Yamamiya and other researchers show that even a 5-minute exposure to thin images and videos would affect young females' body image negatively. Harper and Tigman conducted a study in 2007 where they studied that whether viewing thin idealized media images would affect female state of self-objectification, appearance anxiety, mood, and body dissatisfaction or not. Results show that females who watched thin idealized media images were more likely to have a negative mood, the dissatisfaction of their body appearance, and weight-related appearance anxiety. Also, they found that females who were exposed to thin idealized media advertisements demonstrated higher levels of state self-objectification. It is expected that 50% of individuals who undergo anorexia will develop bulimia nervosa. That's very sad, or at least to me. So how exactly do you treat it? There are various experimental treatments for anorexia nervosa, but according to research, cognitive behavioral therapy model may be the best suitable approach to treat this disorder. So what is cognitive behavioral therapy? It is a therapy that is targeted towards eating disorders in a planned, organized, flexible, and timely manner. This treatment is normally 20 sessions long for people with BMI of greater than or equal to 18, but people with anorexia may need more sessions since they may experience anorexia, psychopathology, which is the fear of gaining weight, losing their shape, body, and limited eating. People who have a BMI of less than 18 may need 40 to 50 sessions with further rehabilitation to achieve better results. The real question, however, is that why is this treatment better than other possibly available or experimental treatments? Individuals with anorexia nervosa are normally afraid of the change the body will go through, which would require them to compromise on their food restriction. This treatment will inspire and motivate change and will aid in reducing patients' fear. There is a high rate of dropouts since many patients are afraid of a change within their body, which is why it is important for the counselor to communicate and engage themselves with the patients. It is important that the counselor make the goals of the treatment clear so the patient knows how the cognitive behavioral therapy will change their body, which will, of course, help them reduce their fear. So what happens in cognitive behavioral therapy? Before we even talk about what happens in cognitive behavioral therapy, let's just see what happens even before the treatment even begins. The patient will be assessed, which will include personal information regarding life, fears, difficulty eating habits, weight history, and medical risk. Furthermore, it is assessed that if the patient does require CBT or not, and the participants would, of course, have to go through a 4-stage program of CBT for them to achieve any significant results. However, once they have passed that and it is assessed that they do require CBT, or cognitive behavioral therapy in other words, it is consisted of 4 stages. The first stage of therapy involves 7 sessions, which focuses on changing behavior. The main component of this session is called psychoeducation. This helps patients understand and maintain the process. It also helps to educate about risks and myths related to eating disorder like anorexia nervosa. The second stage is a systematic review, which is the eighth session, and this session basically evaluates the treatment process. There are three main goals of this session. The first is to recognize the symptoms. The second goal is to ensure that the client is engaged, and the last stage is to organize the rest of the treatment. Moreover, the third stage of the treatment begins from session 9 to 18, which maintains the eating disorder and reviews stage 2. In this stage, a pie chart technique is used, which is divided into shape, weight, and self worth. Some parts of the slices will grow, or new slices will be added. Lastly, the fourth stage means the session has ended and it concentrates on reviewing the last three sessions. At this stage, everything the patient gained has to be maintained. There will be a follow-up review every 3 to 4 months to ensure the patient is in good standing. A maintenance plan will be given to enhance certain areas the patient may still need. This slide demonstrates one of the studies that we found, which assessed the cognitive behavioral therapy intervention by applying it towards the 32 patients at the University of Iowa with anorexia nervosa. It is called the effectiveness of cognitive behavioral therapy on changing eating disorder symptoms and psychopathology of 32 anorexia nervosa patients at hospital discharge and 1-year follow-up. The study is aimed towards using cognitive behavioral therapeutic model to assess changes in people for core eating disorders, psychopathology, depression, general psychopathology after implementing the treatment. Cognitive behavioral therapy has had significant amount of success with treating bulimia nervosa, but nothing has been done in regards to anorexia nervosa in such manner. What's more astonishing is the fact that those patients who do not recover from anorexia nervosa move on to develop bulimia nervosa. While moving on, the study included 32 patients who were admitted to a hospital in Iowa. They were, as usually under clinical practice, assessed prior to and after the treatment. First assessment took place at the discharge interval, whereas the other assessment took place after a year follow-up period. So what did the intervention really included? Basically, this study paired cognitive behavioral therapy with nutritional rehabilitation. Doing it this way will allow the researchers to change the behavioral habits of the patients, as well as allow them to take control of the dietary habits. However, as cognitive behavioral therapy is very broad, the study used certain aspects of it. They used individual cognitive therapy, group cognitive therapy, and family therapy. Lastly, the study utilized two instruments that are eating attitudes test and eating disorders inventory. But the good question to ask is if the study was really successful in whatever it was trying to achieve. The results of this study did show that the intervention seemed to be working for the patients enrolled under the treatment. At discharge, all patients displayed significant change in core eating disorder, psychopathology in their depressive symptoms, as well as in general aspects of psychopathology. Moreover, at 1-year follow-up, changes in some areas of core eating disorder, psychopathology, and depressive symptoms continued to be significantly different than when they were admitted into the hospital. As stated earlier, this study is utilizing two instruments. So in one of the instruments that is called eating disorder inventory, they did observe 8 differences from the 7 aspects of the inventory. That includes bulimia nervosa, ineffectiveness, perfectionism, interpersonal distrust, interoceptive awareness, asceticism, and social isolation. However, in terms of the results of the intervention, patients did reported a greater sense of personal adequacy and control over their lives, had changed attitudes regarding the use of extremely high personal standards. They also reported fewer, less intense somatic or bodily concerns, less worry, less discouragement, and an overall improvement in their mood. They also viewed themselves as having fewer obsessive thought, less fear and anxiety, more confidence in their own ability, and saw themselves as more secure and comfortable. Stats-wise, patients also reported their attitudes towards being fat, eating, and being out of control. They continued to be less distressed about being thin, had fewer thoughts about binge eating, experienced a greater sense of personal adequacy, modified their view on extremely high personal standards, and reported continuing to be open to forming close relationships. Most of the participants in the study were within 95% of their target range of their desired weight by the time of retesting, which shows that the intervention worked and improved psychopathology. The combination of CBT and weight restoration can significantly reduce eating disorder symptoms, depression, and general psychopathology during hospitalization, with some sustained benefit over a 1 year period. However, one aspect of the study is really problematic, that being it only consists of 32 patients that are admitted to the facility for anorexia nervosa. The study sample is significantly smaller than most researchers would like, thus it can't really be generalized for the rest of the population. To combat with this, more research on the topic would be required with a higher group sample, so the study is more generalized for the rest of the population. Characteristics and stats mentioned, it is evident that this is a significant issue that needs to be dealt with. By introducing certain aspects of the cognitive behavioral therapeutic model, it is possible that we can somehow uproot the cause of anorexia nervosa and create a treatment that is feasible for those patients diagnosed with this ailment. These are the references that we used, and thank you for listening to our presentation.